Today I'm joined by Dr Michelle Cotellessa, a GP, women's health advocate and the co-founder of Hera Menopause, a Perth-based clinic dedicated to transforming the way women experience and manage menopause through innovative evidence-based care. With over 20 years of clinical experience, Michelle has a deep understanding of the physical, emotional and social challenges women face during menopause. It can be so daunting to speak to a stranger about what you're going through. So in this conversation, we're breaking down exactly what you can expect from a menopause appointment. What should you bring with you? What kind of questions might be asked? How can you bring up HRT with your doctor? What if you're feeling unheard? How do you advocate for yourself? Michelle is a wealth of knowledge, and I hope that anyone feeling nervous about seeking help feels empowered by our conversation, equipped with the tools to embrace this phase of life with confidence and vitality. Let's get into it. So, Michelle, you have created an incredible clinic in Perth. I'd love you to tell me a little bit about it and why you decided to open that business.
Well, I guess it starts from the beginning. Like, I've been a GP now for about, 27 years. And I think that love of women's health really started probably back in medical school days. So it really did stem from women's health and went on from there. And then in general practice, that was a lot of what I did. Obviously, being a young female doctor, we do attract women, right? So early in those days of general practice, sort of going into that past WHI, and all of those things, I thought, gosh, how little I actually know about menopause. And back about 10 years ago, I met Sunita when we were working at Third Avenue Surgery. And we both really decided that at that point that we really enjoyed menopause. So it came to a point where it really got to a stage where we, that really a 15-minute consult wasn't cutting it for many of our patients. And we bit the bullet, literally. And 2 years ago or 18 months ago, decided that we're going to do it. So we set up Hera about a year ago. And haven't looked back since, really. And we're busy and we love it. And unfortunately, booked out until August next year. So it's really been an amazing journey of creating it. And we're really the only sort of private menopause dedicated clinic in Perth. It started with the two of us, and we've now got 2 GPs that work for us, and they do a day each, and they're wonderful.
Okay, amazing. So tell me, I know that, we have very similar outlooks at how we approach menopause and how we approach the appointments. I think, like me, you've got quite long consultations because there's so much to go through, right? Like, you just can't get through it in a short period of time. But
yeah.
Tell me a little bit about what a consultation would look like at your menopause clinic.
Okay. So a menopause consultation is a very comprehensive consult. So it really does start with a woman really detailing her main concerns, about what she's presenting with, and a lot about past medical history, a lot about family history, a lot about screening, and also a lot about what her goals are and what her main concerns are. So our consultations at Hera, our initial patient consultations, can range anywhere from 45 minutes to an hour. And in that consult, or prior to a patient, when they book, they'll get a booking form. And on that booking form will be a list of questions about, and this will range, and we can go through that together, but this will start with a symptom scorer chart. And on that symptom scorer chart, there are about 28 points and 28 questions listing varying symptoms that can range from physical symptoms of menopause and then mental symptoms of menopause, cognitive symptoms of menopause, genitourinary symptoms of menopause. There are so many. And then end up with just the impacts on work, the impacts on life, the impacts on connection. So they will fill that out. They've also got a form that goes through many questions. So those questions, I can go through those now with you, would be a range of looking at, when their menstrual history, when was a woman's, last menstrual period? when was a woman's initial menstrual period, can tell us so much about it. And also then looking at period changes, which are a big part of that. So we start with all of those questions. And then when a woman gets into the consult, this is what we're going to start talking about. So I can go through that with you now.
That would be really helpful.
So what we look at is when we talk to a patient initially, by the time generally they have seen us, they have been to see either GPs or they may have seen their gynecologist for varying range of symptoms. And other times patients may have seen cardiologists, rheumatologists, because of the varying nature of symptoms that women can present.
Psychiatrists as well.
Psychiatrists, you name it. So, and the symptoms are as individual as the woman in front of us, and women present very differently. And a woman is never too old to present with perimenopausal symptoms. You can range from your 30s to your 40s to your 50s. So when we have a patient sitting in front of us, they may often be distressed. They may often be very anxious. They may often be very sad. So you're really sort of sitting in front of someone and you can learn so much from a face-to-face consult, which is what we love as well. So quite often when she's walked in, I've had a look, and I've had a look at this new patient form and had a look at her variants of symptoms. And we start with the main concerns. What is it that, what is it? What is that impetus to come and see us? And quite often that is the most vulnerable stage, when a woman presents to you. And so how we manage that is going through all of those symptoms with her. So, when a woman hasn't had her periods for 12 months, it often goes on a different path of, going through the consultation. But often many women are coming in with a multitude of symptoms. And just having someone listen to you often is a really big thing as well, and acknowledging that these symptoms can be perimenopausal.
I agree. I think for women to come in and feel like they're being heard and not being dismissed or made to feel a bit silly, or that they've got, a lot of women will tell me, I just felt a bit silly because I was saying that my hip was hurting and I was having palpitations, but I was also feeling anxious, but my hair was falling out. And I just felt like clearly I was sounding like I was a bit crazy. I mean, that's what they say.
Absolutely.
And I don't know about you, but definitely lots of tears happen in those consultations. A combination of, I think, of relief and frustration.
Absolutely.
Frustration of what they've been through and relief to finally hear someone go, well, wow, this is quite a common thing. So you're not weird.
You're not going crazy.
Yeah.
And it is sheer relief on their face. And also when we go through and educate women, you're presenting with these symptoms. You're presenting with heavy periods. You can often present with, irregularity of periods, erratic nature of periods, but also erratic nature of mood, and often fluctuating mood. I want to, I'm shouting at the kids. I'm not concentrating at work. I'm intolerant of everyone around me. They can be quite distressing because the impact.
In relationships is massive, and they feel like, I've had women come in and feel like they're on the last straw of their relationships with their maybe their teenage kids, or maybe their partner, or even maybe work colleagues. I've had women come in and say, like, if I don't sort this out, like I'm going to lose my job, or I'm going to lose my relationship, because I know that I am really going from 0 to 100 over really small things. I'm getting really angry really easily. And it's very distressing for people.
Oh, it is extremely distressing for people. And I guess, I've learned so much from my patients in the last year, because, the impact, particularly now that we're talking about impact, but women that are resigning from positions that they have such experience and knowledge and confidence in, and that loss of confidence in something that they have done for many years, but women wanting to leave their husbands, or that disconnection with their husbands, and their disconnection with their kids, and just being able to say, okay, there might be something that we can do about this, and giving them hope, I think, is the other thing as well.
Yeah, absolutely.
So when we often, listen to symptoms, it will get on to that point where we show them like the impact of estrogen. So education is part of that consultation as well. After, when we're talking about symptoms, you're saying, well, this is actually the impact of estrogen on your body, and in terms of particularly that neuroendocrine, particularly on brain, is incredibly impactful, and particularly in those early perimenopause where they can be really innocuous, that you're not picking up on those things of irritability and anger, that can start very early on. But even those dips in premenstrual symptoms often for women, particularly, and this is where we go to with menstrual history, that if they've had a history of, in teenage years and in their 20s of knowing that those 2 to 3 days before my period, I am absolutely moody, or particularly significant, I don't leave the house. I don't want to talk to anyone. I'm withdrawing. So picking up on those really early changes in symptoms when you go back historically, which is a really important part of that history taking, saying, how were your periods? Were they regular? Were they irregular? And how did you feel? What did you have any mood-related symptoms prior to periods? What changed? And often you find as they're going through perimenopausal symptoms, those mood symptoms link them. So they can go from a couple of days to women saying 2 weeks out of the month, I don't leave the house. I don't talk to anybody. I'm isolated. I am so down. I am so anxious. I am so overwhelmed. I haven't fed my children for the past couple of nights. And that is heartbreaking. And they've often done this for years because that awareness of hormonal flux is not there. And that comes on to a lot of women go, oh, didn't even know that was a symptom. Oh, why is my back really itchy? Why am I feeling so fatigued? Why can't I exercise the way that I used to? Why am I so bloated?
And the other one as well is, I don't know about you, but also they'll often say, but I don't have hot flushes, so I thought that it couldn't be.
Correct.
The perimenopause and the menopause. It's like, God, the fixation about hot flushes and everyone talking about hot flushes, but I don't know about you, but it's definitely not the biggest complaint that I get at all.
No.
And you're absolutely right. It's those mood and brain, what I call the brain symptoms that are so, so tricky. But, I just one message is like, some people never have a hot flush, but they could have 27 other symptoms.
Correct.
But you don't have to have a hot flush for this to be, it's not like a mandatory symptom.
It is certainly not a mandatory symptom. 20% of women don't have hot flushes. And to tell you the truth, no, it's not the most common. But I do have women, and it can be so varied in terms of women who can have 20 a day, even sitting in front of you, Imogen, Imogen Crump. It is that whole feeling of, I just feel weird, and you know that it's coming on, and it's quite anxiety provoking. But then there's women who have none. And then there are women who talk to their friends and say, but I don't have a hot flush or a night sweat. Maybe I'm not in perimenopause, but I've got those varying other symptoms as well. The muscle aches and pains. I feel like I'm 90 is a really common thing. I feel like I can't get out of a chair in the morning.
Yeah.
That's not right. That's not right when you're 42. It's not right at any age. So, the variants of symptoms. So once we go through those variants of symptoms and talking about their menstrual history, it's also talking about things like contraception. I thought I couldn't get pregnant when I'm perimenopausal. You absolutely can get pregnant when you're perimenopausal. So talking about contraception is really important, and what your goals are, what your fertility goals are, and what, are you still prepared, are you still wanting to have children, or have you finished your childbearing years? And what problems did you have with your contraception in the past? Women that we talk about, why did you put, how was it like? How did you feel on the pill? I was really moody. Or, the Mirena IUD, I felt really moody. It was great when it came out. So knowing that history can then obviously be very helpful for how we manage you in the future as well. So contraception-wise is really important. So family history is another thing that, and when it comes to preparing for your menopause consult, actually knowing a little bit about your family history, if you can, is very useful, particularly for things like clotting history. So if you've had a family history of a few first-degree siblings having blood clots, or migraine with aura, or cardiovascular disease, anyone that's had a heart attack or a stroke at quite a young age. And young age, I mean, 60s even is a young age to have a stroke or a heart attack. So knowing that family history guides us into screening as well. And talking about, we often talk about, have you had a cholesterol check? When was the last time you had your blood glucose checked? When was the last time you had a mammogram or a cervical screening test? That's a really big part of the consult as well. Doing your fecal occult bloods, your poo tests, your bowel screening tests as well. So screening is really, really important. And the other thing we ask about is your past medical history, right? That's also really important in any general practice consult. Have you had operations? Have you had any significant history that you have had to see a doctor about? So we talk about that as well.
And the past psychiatric history in terms of postnatal depression,
definitely.
That's very relevant as well, isn't it?
Absolutely. So mental health history, which goes back into that. Have you ever had a history of premenstrual symptoms or, yeah, that's exactly right, postnatal depression or even anxiety and depression that may have been diagnosed premenopausally can often be exacerbated, particularly in perimenopause. We've had patients with postnatal depression and that ends up morphing into perimenopause. Women who have had children in their mid to late 30s that stop breastfeeding. And you sort of expect, okay, there might be a period of time that your periods don't come back, but it's when they don't come back regularly.
Yes.
And you start noticing those changes in yourself. You might not feel like your ordinary self, your energy's down, your mood has declined. So, yeah, that's really important in terms of that as well. We often ask about obstetric history as well, in terms of how were your pregnancies? Did you have any complications with your pregnancies? Did you have difficulty falling pregnant? Is really important as well. Looking at, did you require IVF? Did you have a history of endometriosis as well and painful periods in the past that also can impact on future management?
So I'm going to ask you, just stop me there and ask you just two quick questions. So, and definitely had a lot of patients who've had IVF and a few of them have been literally told by their treating obstetrician, you're potentially going to have an earlier menopause because you've got, very, very low egg reserve. So is that a thing?
Oh, well, I think certainly we delve into that history pretty, in terms of, I think that's really important. And then you can really sort of focus on how you felt after you had the children too. And also the impact on future fertility, right? But you do hear stories that, you've been told you've got low reserve, but you may have had PCOS too. Then we know that you can still ovulate, right? But yes, I think that's really important in terms of what the patient in front of you wants to do in terms of the future.
Okay, so we're talking about past obstetric history, and then where do we go next?
Yeah, so then we screen about sort of osteoporosis and cardiovascular disease risk because, as we all know, that sort of after menopause, a number of things happen on that estrogen decline. We are at higher risk of cardiovascular disease. We're sort of dwindling down, sort of underneath the men's, the men's sort of cardiovascular disease. But then towards menopause and perimenopause, that risk starts to escalate. We creep up to men's risk in our, sort of past menopause. So screening for any risks for cardiovascular disease. So that would include smoking history, history of alcohol use, and also a first-degree relative. So, a significant family history of heart disease, and high, checking on blood pressure screening is important as well. So we look at all those screening risk factors. And like I said before, when was the last time you actually had a really good preventative health screen? And then the things that we do, we can talk about too. In terms of bones, we ask questions like, have you ever had a fracture? And obviously a lot of us would have had a fracture in our early days, but a fracture, what we call due to minimal trauma. So it's generally a fracture from standing height. We hear about patients, don't we, that, hip fractures are, the common nature of hip fractures now, hip, spine. So we talk about, have you had a history of fracture, or do you have a significant family history of fracture? That also goes on to dietary history as well. Do you have any limitations to your diet? Are you perhaps vegetarian or pescatarian, or have a lactose intolerance, or don't have a good intake of calcium? They're all really important in terms of what are your risks going forward, particularly women who are having really heavy periods and also are vegetarian. That risk of iron deficiency goes up. And quite often those conditions can also exacerbate those symptoms of perimenopause as well. If you're iron deficient, you're going to feel pretty tired along with your perimenopausal history.
Yeah, absolutely.
Yeah. So bones are really important. So all those screening tests are an important part of that consultation. We talk a lot about lifestyle as well, in terms of, we know that women, struggle a lot in those times, and they struggle to move. They struggle to exercise. They struggle, to actually fit all this into their day, to have a good meal plan. The number of stories that you hear that I skip lunch, I skip breakfast because I'm just too busy looking after my kids and not looking after myself. So nutrition's a really important part of that consultation. How do you eat? Do you have a varying diet? Do you include protein in your diet? Is a big part of that. And also lifestyle. How do you move? What do you like to do? What's a good part of your exercise plan is talked about. And then obviously towards the end of the consult, we talk about how you can manage that. And quite often women generally feel better once they're actually treated, and that definitely does help. Yeah.
And what about sex and relationships? Because that to me is a big reason that people will often come in. How do you approach talking to that? Because I know lots of women maybe listening feel a bit anxious about what they're going to be asked, but often are relieved to be asked. So how do you approach it, Michelle?
Yeah, no, it's a fabulous question. And I think you approach it with care and sensitivity. And I think it isn't such an important part, because women are often not asked about genitourinary symptoms, are often not asked about vaginal discomfort, discomfort with sex, dryness, because they're either embarrassed or culturally or socially it's not talked about. It's a bit of a topic, but we approach it with, I often say that this is a really common symptom, that our bladder symptoms, we start developing more bladder symptoms, that I've got to go to the toilet and I've got to go really quick. Often mapping out areas in shopping centres that you can find a toilet. Women that often don't go out and, avoid hiking, avoid doing those things that they love because of bladder symptoms as well.
Or planning their driving route, that they know where the bathrooms are on the way.
Yeah, absolutely. Women who often reps and move around, that have to stop many, many times and find a public toilet. But also those impacts on sexual function, because it's uncomfortable to have intercourse. And like I said, we approach it with care, and I approach it with, this is a really common symptom, and, would you like to talk about it, and vaginal dryness. But the fact is, we can do something to help with that. Vaginal estrogen can be a game changer for women. And just knowing that you can do something about it, I think is just so relieving, because it can impact on relationships and intimacy.
Absolutely. And what about the patient who has or hasn't got vaginal dryness but just has no libido?
Yeah.
Lots of people will tell me their libido went on holiday a few years ago and didn't come back. And how do we approach that?
Yeah. Oh, gosh, I think I would put no libido. We call it sub-zero libido in the clinic often. It's one of the most common symptoms, that and weight changes. Libido, we approach with, and I often say to women, it is multifactorial too. There are so many impacts on a woman's libido. It is very centrally located in our brain. And I often say it is very common. And we tackle this with a variety of ways. So I often do something called a desire screener, and it's a series of questions that looks at how your libido impacts on your life. I've got women that it doesn't really matter to them, and their relationship is that they're actually very happy and they're both very equal in how they feel about their sexual function. I've got women that say, I would be happy if I didn't have it again. And I went, okay, that's very personal preference, but often saying that, you know what, there are things that we can talk about and do about to help with that, and just giving them that knowledge that there are treatment options, and it may be ranging from counselling. It may be ranging to just improving their sexual comfort with vaginal estrogen and lubricants, to testosterone as well, which we do use for hypoactive sexual desire disorder. But we do know anecdotally that it can have some really good impacts on many women on mood and cognition and fatigue and muscle aches and pains too. But that's quite anecdotal evidence at the moment. But we do see that clinically quite often.
Yeah, me too, 100%. And I think the other thing as well is that, probably for men and women, but definitely for women, if you're feeling so exhausted and you can't sleep at night and you're feeling a bit anxious and you're not loving and feeling confident in your appearance, well, that in itself is going to really impact your libido as well. So, I think it's actually, ticking off the boxes for a lot of the interconnecting symptoms.
Correct.
And then you get the whole package that often improves. Is that your experience?
Absolutely. And it's just acknowledging that absolutely that all of those symptoms can impact on a woman's libido, and knowing that if we can talk about it and we can tick those boxes and manage them as the best way we can, and we've got tools.
So clearly you and I come at this the same way. It's a very comprehensive consultation. It does take a long time.
Yeah.
What tests do you send your patients off to have, and any?
So it all does depend on the individual patient, as you know, and what their risk factors are, what they haven't had done. So quite often in a consultation, for many women, I would send them off for screening pathology. So firstly, that would comprise of things like a blood count and an iron and a thyroid, and obviously very individually based depending on their symptoms.
Of course.
But also include things like your lipids, your cholesterol levels, your sugar levels, but also things like I would include B12 and folate. I wouldn't do anything like hormones. Only for certain circumstances I would check your hormones. And we know that in perimenopause it can fluctuate so wildly that, in a spot of time, your estrogen, you might be told your estrogen's really low, right? And you could check it 2 weeks later and your estrogen's really high just because of that variance. So quite often I wouldn't do hormones. At times I would do your baseline testosterone, particularly if we're thinking about commencing on testosterone, I would do that as well. If a woman hasn't had a bone density, I absolutely have very low threshold. Majority of my patients would get a bone density because I think it's a great screening tool. It's not reimbursed by Medicare unless you're 70 or other pre-existing conditions, and you may be able to get it reimbursed. But I believe by the time you're 70, the ship has left the dock. This is where you're going to get a good early screening test of where your bone reserve sits. And that can be quite interesting for women to know, what I need to be doing to improve my bone density. Yeah.
I often do say to women who are sort of on the fence, and I obviously understand that it's an expense to have the bone density scan, but it's such an investment in your future, because you've only got to look at women who have bad osteoporosis and they are literally crippled with pain. They're having spinal fractures, and their day-to-day life is so impacted that, it's such a, in the scheme of things, it is a small investment for us to know if there's an issue so that we can deal with it before you get to that point.
Absolutely. You've absolutely said it beautifully. It is an investment in your future, really, of knowing that. Yeah. And also importance of checking up on mammograms. Are you due for a mammogram? Have you had a history of breast density? and quite often thinking about a clinical examination plus even a breast ultrasound too to check up on that. So they would probably be my top tests that I would do. In some women, a CT coronary calcium score, so doing some cardiovascular screening, particularly if they've got risk factors or a really significant family history. I'll discuss it with my patients. Say, look, this may be a screening test. It's not a diagnostic test, but it can give me a lot of information in terms of, where the potential is of what's your risk of cardiovascular disease as well, and obviously the importance of hormone therapy in that really good window of opportunity where we can make a big difference for prevention.
And Michelle, whenever those blood results come back, I often see these cholesterol levels that of people who've always had good cholesterol, in the normal range, and I include myself in this. I went from having a cholesterol of 4.2 to suddenly having cholesterol in the high sixes. And that's definitely a bit of a pattern that we do see at this stage. Is there any other blood tests that you say, oh, I often see that one's gone off a little bit, or, I often see a bit of vitamin D deficiency. I think that's because Australians, you're probably in Perth, it's a bit sunnier, but where we are in the winter, everyone hibernates and they seem to get vitamin D deficient. But is there any other things that you see? Obviously, the iron deficiency with the heavy periods.
Yeah. I think my top ones, definitely vitamin D. Even in sunny Perth, we live in a different, we live with sunscreen. We live with working a lot indoors, than we used to. So vitamin D is really important to pick up on screening. So yes, vitamin D and iron is another one. You see irons that are just dwindling low and often can exacerbate that fatigue too, is making that decision on treating low iron, treating low vitamin D as well, which can impact on bone, and so, yeah, absolutely.
Are you feeling lost? Don't recognize yourself? Feel like your body is betraying you with weight gain and belly fat? Are you losing sleep and feeling irritable or anxious? Are you bone tired yet unable to sleep? And are you feeling confused about hormones? Should you start? And if you do, when on earth do you stop? Well, I'm so excited to let you in on a secret that we've been planning for over 6 months. On Monday, the 3rd of March, 2025 evening at the Art House in Wyong, we are bringing you the best of the best education on menopause, hormones, sex, exercise, and more. We will have the incredible, world-renowned expert orthopedic surgeon, Dr. Vonda Wright, who's also a huge advocate and educator in the menopause world. We will also have the wonderful and witty Dr. Kelly Casperson, globally renowned urologist and specialist in menopause and all things urinary and sexual health. They will be joining me, your very own Dr. Shauna Watts, for an evening of fun, laughter, and maybe even some tears. We will also be raising funds for the Debbie Gaunt Foundation, a local charity that is very close to my heart. Tickets to all of our events have historically sold out, so grab your seat by heading to thearthousewyoung.com.au/what's on. Obviously, we know that hormone replacement therapies had a bit of a renaissance, and people seem to be much more interested in it. I've been trying to really understand in my mind why it's happened over the last few years. I have various theories about more female doctors and maybe more female doctors themselves becoming peri and postmenopausal and all sorts of things that I've got, maybe social media, but whatever the reason, clearly hormones are being talked about a lot more. But I find that there's still a lot of fear comes through the door with hormones, and patients will often say, oh, well, my granny had breast cancer, so I can't have hormones. And do you feel like you spend quite a lot of your consultation reviewing that?
Oh, absolutely. It's a big part of the consultation. So this is sort of when we get into our management side of things as well, and that's where the family history starts coming into it too. And often before, when women come in, they have already been told, I've got a family history of breast cancer, I can't have HRT. I have had a family history of clotting, I can't have HRT. So it's actually debunking those stories, because you can actually still have hormone therapy when you've had a history of or family history of breast cancer, and in certain circumstances a history, but that's a detailed and different conversation. But particularly a family history, it's just that awareness that the body identical hormones that we are using now, the estradiol and the micronized progesterones, do not actually cause breast cancer. And all of us have a baseline risk of breast cancer, of 1 in 7 of us. And having a family history may not predispose you to a higher risk of breast cancer, but that's not excluding things like, genetic mutations that run through families. So it often requires a detailed, individualized discussion, but often it is about the woman in front of you, and having those individual risk discussions is really important, but also saying it's not going to be a contraindication. Yeah, and giving the woman the choice is really important too.
Absolutely. Yeah. And as you said at the beginning, we both experience this where patients, often by the time they get to us, they have maybe seen 3, 4, 5 health professionals, and they've maybe done a lot of their own research, but they're very anxious that they're going to be yet again disappointed. Would you have any advice for anyone who's feeling really worried about going to their consultation, about, how they might be able to prepare or feel like they're a bit more in control? Because, we understand as doctors, there is a bit of a power dynamic differential. People can feel a bit intimidated, a bit nervous. We know that people will often rehearse in the waiting room what they're going to say because they feel a bit worried.
Yeah.
But would you have any advice for anyone who's worried and how they might approach the whole situation?
Absolutely. That's a really, really good question, because it is something that I think certainly even in the main concerns when women come to see me at first, you often are told that, I've been to see another, many GPs I'm a GP, and have been told I can't have it, or I'm too young for perimenopause, or all those other symptoms. So I think my biggest tips to prepare for a consultation would be, 1, to really journal. I think journaling your symptoms is so helpful. And whether that be, using a calendar or using your phone, but just jotting down what your symptoms have been. And that can be anything, even if you write down one day. I've had women that write down one day I'm moody, the next day I'm irritable, the next day, where's my period? Erratic periods. Write down your symptoms, and they can be a really useful clue for a doctor as well, to actually look at your severity of symptoms and how they've trailed over time, but also the awareness of your own body. Women know their body. Women know that they've changed. Women know that they don't feel themselves. So advocate for yourself. Advocate for your symptoms. The other thing is, do your research as well. Maybe talking to friends often and family about which doctors they've seen. What good outcomes have they had for themselves. And at Hera, that's pretty much how we've got a lot of our patients. There's obviously previous patients, but word of mouth. And I think that's really helpful as well. And also getting the education. And quite often, look, we all know that the social media, it's exploded. There's so much out there. There's so much misinformation still out there. But getting to some good resources as well can be really helpful. So for us, it's, certainly things like the Australasian Menopause Society has probably been, sort of one of the Australian ones, but even through the British Menopause Society have some really good information too. Our friends at Healthy Hormones, who have developed a website, can be really helpful for women as well. So becoming more aware, but advocating for yourself and knowing your own body as well.
And do you think there are any sort of mistakes that people make going into their appointments, or anything that they should avoid?
I would say always book a long appointment. So book a long appointment when you first see your GP. The other thing is, there are a few GPs in a practice potentially going to somebody who may have some women's health experience, as and I think the other important thing is, you know your symptoms, and just advocate for yourself when you're in there too. And really have a goal, have a goal of what you want to achieve from that consultation. And if you're disappointed by the consultation or it didn't meet your goals, perhaps find another practitioner who may.
Yeah, have a second opinion if needed.
Yeah.
But also I think have an open mind in that, you know, even if you see a clinician, for example, we're not going to potentially give everyone testosterone. So just because, you know, you've watched something on social media, you know, and there's no doubt that testosterone can be really, really helpful, but it's maybe not for everyone. And there may be a reason why the doctor may decide that that's maybe not the most appropriate thing to help you with your symptoms. So I think I would say come in with a bit of an open mind, not too rigid about what you want, because we actually might have an even better idea for you.
Yeah. It's a really tricky one because I see we see patients that have often, you know, come to a menopause clinic with a potential goal in mind. So, you know, in general practice, it can be a very different outcome that the GP may not be confident in prescribing HRT at that point in time. So that's where it gets really tricky, doesn't it?
I agree. And I think one of the things just to acknowledge to all the listeners is there's no doubt in my mind over the last 20 years, not only GPs, but obstetrician and gynecologists, endocrinologists, we've all become quite deskilled in prescribing hormones because for years we were pretty much encouraged not to prescribe them. And so if you don't do something, you become deskilled at it.
Absolutely.
And that's just, unfortunately, the reality of where we find ourselves. And there's lots of us who have been scrambling to really educate ourselves because we have various interests.
Yes.
But I think the reality is that sadly there are people who are just a little bit further behind in that process. And it's not in a vindictive way. It's just that perhaps they don't know the new thinking per se. So I think there's a level of de-skill has happened, and it's unfortunately trying to find someone who seems to be quite interested in it.
Yeah, and that can be really tricky. And look, hopefully over time, what we're advocating for is better education for doctors, allowing them to be more confident in prescribing HRT, and even just for the more simple consults, you know, the more complex consults you can refer on for, you know, if it gets tricky. But at least, you know, prescribing HRT, I think it definitely could help many, many, many patients out there. Yeah.
I don't know about you, but I have to say we tend to do my reviews around 4 to 6 weeks after beginning hormones. And certainly as a doctor, I love those consultations because the vast majority of the time the person sort of skips back in the door. Yeah. And as a doctor, you're used to, you know, maybe starting antidepressants or blood pressure medication or diabetes medication. And you often don't see a very quick response with those things. But I think what's interesting is a lot of the time with hormones, it works quite quickly, doesn't it? Yeah. And the person is like, yay, slept. And it certainly feels pretty good, doesn't it?
Oh, it certainly does. And look, I think doing menopause medicine for me has been incredibly rewarding, and I love what I do. And, you know, you can, you know, within sort of 6 weeks to 8 weeks, and we normally follow up, you know, probably at the moment, probably about 8 weeks or a little bit further. But, you know, patients can come back feeling amazing. And others, it can take a little bit more time because our bodies are so different, you know, how we absorb, how we metabolize, what other pre-existing conditions a woman may have. So it can be quite varied.
And just getting that dose right as well. It's not everybody. You get it right first time.
It's not one size fits all, and not everyone responds to the gel may respond better to the patch, may respond better to a tablet, might get side effects from a different progesterone. So we are also very different, but the importance of review and continuity is vital because the tweaking that happens, you know, over time, you know, and over time your dose will change too. So we see all those appointments, you know, and often we'll follow our patients up at, you know, 2 to 3 months, and then it might be another 3 months, then it might be 6 months, and then you might graduate to annual. So there is that period of time of review and changing, and quite often then adding in other hormones like testosterone too. So there's always a continuum of management. It's never static. And, you know, the end point really out of all of this is to make, you know what our favourite is? I feel normal again. I love that. That's my favorite. I feel like myself again. And that's just amazing. Yeah.
That's what we're hoping.
That's what you want your end goal. Yeah.
For anyone listening, the good news is that we are actually at a conference this weekend, and I think there are 2,200 people here, mostly doctors, all listening and educating themselves for, well, depending on how many days you're here for, but 4 to 5 days, all about menopause. And there's people from all over the world. So we have menopause societies from Korea and Canada and Mexico and the USA and the UK, all here presenting their findings. So there is hope that hopefully doctors and medical professionals are going to, really elevate their game as well and sort of meet the need where it is. Michelle, you've been really, really generous with your knowledge. I think anyone listening is going to feel much more comfortable knowing what is likely and what should happen in a thorough consultation. Is there anything that you feel that we have missed out on talking about?
Oh, Shauna, I think we've pretty much covered the crux of it. And really at the end of the day, I think it's just finding a practitioner that suits you as well and that you feel listened to, acknowledged, and you're getting the education that you need as well. And quite often part of that consultation that we cover, we do give a lot of information. I do send out emails at the end of it, with many resources for women too. And I think it's feeling empowered that's really important.
Yeah. Amazing. Yeah. Michelle, I'd like to finish by asking you something I ask all of my guests on the podcast is if you were able to talk to 20-something-year-old Michelle, what piece of advice would you give yourself?
Yeah, that's a really good question. I think what I would say, I had a really good think about this, and it's just doing things outside your comfort zone. I think when I was young, I was very routine and everything was structured. But if you just live outside that comfort zone a little bit and try something new, you grow, right? You grow in discomfort sometimes. And the other thing I would say is you learn from mistakes. And I think a lot of our personalities, particularly in medicine, is fear of failure.
Absolutely.
So you've got to make the mistakes, you've got to fail, and you live from failure. And I tell my kids that all the time.
I love that. Yeah. You're so right. Unfortunately, doctors, it attracts a lot of perfectionists. Michelle, thank you so much. I've absolutely loved our conversation. I know this one is actually going to be really popular because this is something that people want to know. So thank you.
Thank you, Shauna, for having me. And we're going to now go and enjoy the rest of the International Menopause Society in Melbourne. Yeah, it's amazing.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.